And the topic of the talk today is going to be how to diagnose and treat microvascular dysfunction in a patient with typical angina and no obstructive coronary artery disease, also called microvascular angina. I always like to start my presentation off with the element of a case. So this is a 48-year-old female. She comes with complaints of chest pain for the last 3 to 4 months. The pain increases when she does household work and decreases when she rests and relaxes. Sometimes she even has pain with mental stress, with arguments in the family, some family discord. And she has about 3 to 4 episodes of pain lasting for about 10 to 15 minutes every week. Sometimes they last even longer, up to an hour. Her past medical history is significant for hypertension. She is a pre-diabetic. She lives with her husband and in-laws, and she's actually a homeopathy physician. She has 2 children. On exam, blood pressure is a little bit high. She is obese. Her BMI is 34. The rest of the exam is, for the most part, unremarkable. EKG is unremarkable. No LVH. Labs are also okay. A little bit high triglyceride, a little borderline LDL. She's pre-diabetic. Echocardiogram was unremarkable. Her EE prime. She doesn't have any diastolic dysfunction. No regional wall motion abnormality. So this is a typical patient that we would see in our clinic, right? So as a part of the protocol, she undergoes a treadmill stress test. She's concerned about, she has some cardiovascular risk factors. She goes 7.5 minutes on the Bruce protocol. She reaches 95% of her heart rate. She did have some chest discomfort at 5 minutes, and she did drop her STs with that. She'd had a ST depression in 2-3 ABF, something in the lateral leads. And then, we offered her CT angio versus a possible cardiac cath, and she opted for a cardiac cath. On the cath, she had no significant epicardial stenosis, mild plaque, maybe in the LAD about close to 20% or so. So the question is now we are faced with this thing, right? I mean, is this a false positive stress test? Is it all stress-induced? Is it psychological? We have many times tell our patients, you have nothing, go home, you're all right. Is this a non-cardiac chest pain? Does she have something else which is going on? Or is this something else? Are we really missing something? And that is the basic question that we are here to try and answer. Now, when we think of coronary artery disease, we try and divide it into 2 blocks, right? Either you have obstructive plaque, and if your symptoms are stable, then you have stable coronary artery disease. We all know that. If you have unstable angina or MI, then it's a traditional MI, PCI. We know what to do over there. But what happens when you have non-obstructive coronary artery disease on a cath in a patient who may or may not have, who has symptoms, right? So this could be ANOCA or INOCA, and we'll talk about what exactly these terms are. And this is usually considered syndrome X. Historically, we used to call it syndrome X. Now there are many more names and permutations that have come up. And if you have unstable angina, if you've had an MI, you have clean cath, as we say, then we have MINOCA, right? Myocardial infarction with no obstructive coronary artery disease. And there also, for the most part, we say, you're fine, go home, take some risk factors, take an aspirin, take a statin, nothing to do for us over here. So we kind of need to rethink how we think of ischemic heart disease. This is the traditional model, right? You have epicardial vessels, this is what we've been taught, but the reality is something a little bit different. This is what coronary vasculature looks like. It's a lot more dense, it's like hair, it's like cotton, it's just a lot more than what epicardial stenosis is. Now, before we go forward, I think it's important we try and clarify some of the definitions that exist in the literature. Microvascular angina is myocardial ischemia triggered by coronary microvascular dysfunction. This was previously called syndrome X. Microvascular disease is another term for coronary microvascular disease and includes patients with microvascular angina. It can happen in patients with epicardial coronary artery disease as well. So you can have epicardial disease and microvascular disease both. INOCA or ANOCA, it is non-obstructive coronary artery disease, ischemia with non-obstructive coronary artery disease, or angina with no-obstructive coronary artery disease. And this includes patients with vasospastic angina or epicardial coronary artery spasm. We often see this. Somebody has, a young person comes complaining of chest pain. We say, oh, you have vasospastic angina, and that's where this comes in. MINOCA, we all know, myocardial infarction with no obstructive coronary artery disease, and that is a different element altogether. And then vasospastic angina is variant angina. Now, when you think of the microvasculature, when you think of the entire vasculature of the coronary arteries, there are epicardial arteries that we concentrate on, we think of, we cath them, we study them on CT angio, but there is a whole host of other vessels as well. After the epicardial vessels come the pre-arterioles, the arterioles, and the capillaries. And it is the pre-arterioles and the arterioles that really define a lot of the resistance that comes to blood flow in the heart. And that is very important. But why is this resistance important? Because coronary blood flow is constant over a wide range of coronary perfusion pressures. So to maintain coronary blood flow, the resistance in the circuit has to change. And this resistance in the circuit, including the pre-arterioles and the arterioles, is changed, among other things, by adrenergic stimuli, some local changes in the oxygen tension, response to changes in the transmural pressure. They kind of define and change the resistance of the microvasculature that in turn leads to change in coronary blood flow. Now this is important because your coronary blood flow needs to change, because when you're exercise, when you're in stress, you need more blood flow. Because at baseline, your heart is already extracting maximum amount of oxygen. So to negate ischemia, so to say, your blood flow has to increase. But this microvasculature can go into trouble, right? This microvasculature does have disease and pathology with it. And that pathology can be divided broadly into either a structural pathological issue, which could be microvascular remodeling, or a functional issue, which could be endothelial dysfunction. So this brings up the question of microvascular, so this basically encompasses microvascular dysfunction. And microvascular angina represents about 40% of patients presenting with symptoms of myocardial ischemia with normal or near normal coronary arteries on cath. So when they cath patients for coronary artery disease, when you cath them for angina, when you cath them, about 40% of patients end up having really normal to near normal coronary artery disease. And microvascular dysfunction has a bigger array, more than just angina. It does have a role for various cardiomyopathies. Some people, whether it's there in heart failure with preserved ejection fraction, whether preserved ejection fraction caused myocardial dysfunction, or myocardial dysfunction caused preserved ejection, heart failure with preserved ejection fraction is kind of debatable. It can also happen with obstructive CAD. It can be iatrogenic. You can have it in ACS when we have distal embolization. That causes the coronary dysfunction. It's thought that you have it even in Takotsubo cardiomyopathy. So what are the risk factors for microvascular dysfunction? There are primary risk factors and there are secondary microvascular issues. The primary risk factor profile you see over here, smoking, diabetes, atherosclerosis, hypertension, inflammation, these are very similar to what you have for epicardial stenosis. Microvascular dysfunction, the risk factors are very similar. And then there are secondary microvascular issues that can happen, which could be microembolization during ACS, LVH, hypertension, aortic stenosis, HOCM. All these things can also cause an element of microvascular dysfunction, and that is called secondary microvascular dysfunction. Microvascular dysfunction is more common in younger age compared. So the mean age in most studies has been about 49, and it's more common in women compared to men. So the coronary microcirculation can cause ischemia. It can cause chest discomfort. And I think this cartoon over here really tries to hone in that issue that you have epicardial vessels, you have pre-arterioles, and you have arterioles. Now, when you have issues in the epicardial coronary arteries, you can have stable coronary artery disease, right? That's what we typically see. The Orbita trial and all the other trials we talked about the epicardial stenosis. You can have epicardial coronary spasm. But spasm is a temporary thing. And then when you go into the microcirculation, you can have microvascular disease or you can have microvascular spasm. That's the usual two pathologies that we see in patients with microvascular disease. So how do we define it? How do we say if somebody has microvascular dysfunction or not? So the Covade study group was formed, which published its definition of microvascular angina and microvascular issues in 2018. There are four things you need for it to be called that you have vasospasm or microvascular dysfunction. The first, symptoms of myocardial ischemia. This could be effort or at rest, angina or angina equivalents, absence of obstructive CAD, objective evidence of myocardial ischemia, or evidence of impaired coronary microvascular function. And I will just spend some time over here because if you see, there are these different criteria that you use in practice to define coronary microvascular function. So an impaired coronary flow reserve, we'll talk about that in a second, coronary microvascular spasm, with acetylcholine testing. Abnormal coronary microvascular resistance as defined by an IMR more than 25, or coronary slow flow phenomena defined as TIMI frame count more than 25, and we'll just talk about all that stuff. So what is coronary flow reserve, right? How do you diagnose this? So what you're studying in coronary flow reserve is you're doing hyperemic coronary blood flow versus baseline coronary blood flow. Okay? So we give you an agent. This is all done in the cath lab. At least this example is in the cath lab. You're basically trying to see what is the maximum amount of blood flow that the heart can take versus what it is as baseline. And it is an integrated measure of flow through the epicardial coronary arteries and microcirculation. So it's an element of both, the epicardial and the microcirculation. However, there is another index, it's called IMR, Index of Myocardial Resistance. Over here, they, once again, through some testing done in the cath lab and even non-invasively, no, this is done mostly in the cath lab, it gives you a resistance marker that is a marker only of the microvascular resistance. So this does not take the epicardial stenosis in account. So there are various ways to do this test. There are invasive ways that we just talked about, done in the cath lab. You need special wires to do this. There are special protocols of how you do this. And at least I personally have not really had too much experience in this. And I called up many physicians, and maybe Dr. Hiramat or anybody else in the audience can clarify this, that I don't think this test is currently being done in India for the most part, maybe in a few centers here or there. There are ways to do this non-invasively. And non-invasively, you can do this by using PET, echo. This is a laundry list. You can do echo, you check it on PET, you can do CMR, and even some studies on the CT scan. So there are, you look for coronary flow reserve, you can do resistance testing, you do perfusion reserve, and there are these different parameters that you have with the diagnostic thresholds that are mentioned over here that can be used to define if you do or do not have microvascular dysfunction. Invasively, this is done in the cath lab. The patient is taken to the cath lab. If you do not have epicardial stenosis, and please, I want to clarify this, these tests are applicable only if you do not have significant epicardial stenosis. Only then these tests are being done. So in the cath lab, you take a wire down, you check CFR, you can check for IMR, and this is just an example of a protocol that is being done. This is just one example of a protocol that is used to check for dysfunction. This is also endorsed by the chest pain guidelines, and you can see over here that if you do have, if you have non-significant epicardial disease, if your FFR is less than 8, then you have to check, or you should check for vasospasm, and you should check for CMD, coronary microvascular dysfunction, by some of the procedures, by some of the methods we talked about. So how do we treat these patients, right? So now we've diagnosed this patient. How do we treat them? Just 30 more seconds.
Dr. Gupta, can you wind up?
Yeah, just 30 seconds. I'm almost done. Yeah. So there are various ways to treat it. Lifestyle modifications is important. There are a laundry list of medications. These are the usual medicines we see in the cath lab. There are many medicines over here that you'll see. They are just experimental medications. But can we personalize treatment for these patients? This was studied in the core MICA trial that was published in 2018. And what they did was they did interventional diagnostic test of ACH and adenosine, checked hyperemia and IMR, and tried to personalize the treatment. And they found that if the medicines are personalized to these patients, there is a significant improvement in the quality of life. So coming back to our patient, what we did not have invasive or non-invasive diagnostic modalities. We dismissed the patient as non-cardiac chest pain, recommended some blood pressure medicines. The patient was not convinced. She returned in clinic with recurrent chest pain, had a repeat stress test multiple times outside another facility, which continued to be positive, so she came back to see us in clinic. We talked to her extensively, started her on ACE inhibitors and beta blockers, started the weight loss program. There was significant reduction in symptoms and improvement in the quality of life. So just to conclude, I think it's time to revise the concept of ischemia and ischemic heart disease to include microvascular dysfunction. Coronary microvascular dysfunction is common and frequently dismissed entity in the medical community. It is dismissed because of lack of physician education as well as infrastructure availability, and identifying the precise etiology can guide therapy and improve patient quality of life. Thank you very much.